research project teams. And that's how I get to work with such terrific people like Dr. McDonald. So if any of you out there are really interested in science, you don't have to be a scientist, but if you're interested in it, I urge you to go to Komen.org. You can click on a button up at the top that says Get Involved, and then click on Become an Advocate. And you can learn all about what we do and decide if you'd like to join us, and we'd be thrilled to have you. So that's my plug about advocates in science. And obviously one of the persons that I get to interact with at the University of Pennsylvania is Dr. McDonald, and she is in radiology and imaging. And I think, Dr. McDonald, a great way to maybe get started is if you could sort of describe, why did you pursue a career in radiology in the first place? And why did you specialize in breast cancer?
So the career in radiology was really just a long-term interest in imaging and how imaging can reflect biology. And this all complemented itself with research that I was doing at the time. And I wasn't initially in breast imaging, I was in thoracic imaging, and then my mother came down with breast cancer. And at that time, it was a while ago, she had the standard treatment recommended. She wanted to save her breast, so they recommended chemotherapy, and she had that neoadjuvantly. And she also had the radiation and the surgery. So, you know, I walked, she came to where I was working at the time to get her treatment. So I walked through that path with her, the 8 months of the chemotherapy. And at the end of that, the hoped for result with that was breast preservation. She was already older, she wanted to preserve her breast, and unfortunately she had very little response to the therapy. And so then, despite everyone's best efforts, with that chemotherapy, it was, you know, basically no significant change in tumor size. She wasn't able to keep her breast, but she had the unfortunate side effects from this standard Abramson Taxol regimen of neuropathy in her hands and her feet. She was a pianist. She had to stop playing piano. And so after that whole experience, I thought, can we do better than that? Can we actually use some modality, some companion test to predict who will respond to therapy before they actually get the therapy, so that if they're not going to respond, you can perhaps do something different. And that, you know, at the time, there weren't a whole lot of drugs available. Now there's so many options for people with breast cancer that's become an even more relevant question, because there are so many good options. So let's see what's going to work. So after she had been through that experience, of course, you know, then she had to get the surgery and radiation treatment. So it was quite prolonged. And then I thought, you know, this is what I want to do. So I needed to go back and subspecialty train again in breast imaging to enable me to be the translational researcher that I wanted to be. And so that's how I ended up at the University of Pennsylvania doing what I'm doing.
It's terrific. Thank you for sharing that. I know you're going to talk to us this evening about harnessing imaging to learn more about the biology of a tumor. And I think a lot of us, when we think of imaging, we think mammograms. And we also think about, you know, MRIs and, you know, and other types of things that are basically sort of very often used to diagnose our cancer. And I think you're going to talk to us a little bit tonight about how imaging can go beyond that into guiding us in terms of how we treat breast cancer. So if that's an appropriate way to sort of set up what you're going to talk about, why don't you go ahead and share your screen and we'll bring up your slides. And while you're doing that, just to everybody who is on the call, if you've got questions, there's a chat box down at the bottom. And please feel free to type in your questions. We'll have some time at the end of this hour to be able to hopefully get to most of them. And if we don't, we'll follow up with you afterwards. But utilize that as a way of letting us know if you've got questions or something was not clear. So there you go.
All right, do you guys see this now?
Yeah.
So the title of this talk is Harnessing the Power of Imaging to Determine Tumor Reactions. So while it's an interesting title, we have to think about the only way that imaging is going to determine how a tumor will respond to therapy is if imaging actually reflects tumor biology. Because tumors have different biology, as you're all very aware. We talk about ER positive, triple negative, HER2 positive. You've heard these words. And interestingly, to some extent, imaging reflects that, which is usually a pathologic diagnosis, but then even can go beyond to reflect the biology of how this tumor will respond. So starting, we talk about, can tumor biology be imaged? And then a little bit about normal molecular biology and normal breast tissue, going on to how that relates to breast cancer, and then to one way that we can use imaging to precisely reflect how a tumor will respond is using radiomics, and we'll talk about what that is. So this is about treatment, but it's also about diagnosis. So at the heart of this controversy, which you've all heard of, surrounding screening for breast cancer, is the biology. So not all breast cancers are the same. Cancer biology, the commonality of each type of cancer will vary by age and race and genetic makeup. So biology is already used to inform decisions surrounding treatment. When should a woman start screening? How often should they screen? Is a mammogram enough? What if they have an invasive cancer? Is that going to be an issue? Should they have radiation? Do they need treatment, even if they're diagnosed with something? And all of these questions have to do with the tumor biology. And here, I don't know, can you see the pointer?
Yes.
This is just a picture here of an MLO mammogram. When you get a mammogram, this is what's called the MLO view. It's one of the two views. And this breast has a very low density. And this is another MLO view. And this breast has a high density. And this has to do with the biology of this person's makeup. Depends on what this person will need to screen, because you can imagine a breast cancer on this would be white. It would be this color. Mm-hmm. So here you would see it quite easily, but here you might not see it at all. Is it this, or is this normal tissue? Is this something? And that's why for this woman now, she'd be told she has an increased breast density, and she might have supplemental screening recommended. And this all has to do with biology. In this case, it would be the underlying biology of this breast parenchyma, which makes the screening test, a mammogram, a little less sensitive when the density of the breast is increased. But moving on into biology, it is true that some tumor types do not need chemotherapy if confined to the breast in certain patients, and that is even if they are invasive. So some women nowadays with invasive breast cancer, if you're a certain, you meet criteria and you have had surgery and you've had your lymph nodes looked at, some women can just get hormonal therapy, whereas other women still need chemotherapy. So we want to use tumor biology to develop strategies to guide shared decision-making regarding screening and treatment. So this is traditional medicine. This is more what people were doing when my mom was diagnosed. You have Sally and Molly and Mary, and they all have early stage invasive cancer. They would all like a lumpectomy. And traditionally, they would follow a wheel of treatment, which is the same for each patient. They would have their diagnostic imaging, and that would be where they would be diagnosed, usually with a mammogram followed by an ultrasound. The pathologist would look at a biopsy sample and decide what kind of breast cancer. Often with early stage, they would have surgery first, then they would see medical oncology, and they would generally have radiation. So this is the traditional wheel, and they would all get on this wheel and go through the whole process. But we started to think, well, can we do better? Because precision medicine might have showed us that Mary could have had endocrine therapy. So that's that anti-estrogen therapy. Tamoxifen is an anti-estrogen. There are many different choices. So Mary perhaps didn't need chemotherapy. Sally perhaps didn't need any treatment at all. But Molly needed to do everything. And this is precision medicine, where the treatments can be prescribed based on the tumor biology. So this is the future of breast cancer care. So to understand the precision medicine, we have to go back to the biology of normal breast tissue. So when you hear about people talk about different types of breast cancer, there are the hormone receptors, the ER, PR, HER2, and then there's the triple negative breast cancer that has no receptor positivities. But also you might hear people talk about different types of breast cancers in terms of molecular subtypes. And those would be different words. You would hear luminal and basal as two words people would say. And those actually come straight from the normal breast histology. So this is normal breast tissue, and these are normal ducts here. So this is a normal duct, and it has these cells lining it. And these cells lining it are called luminal cells. And on the outside of the duct is the basement membrane, and there are basal cells. You might think, well, why is that important? It's important because the breast cancers that arise from these different cell types would be treated differently. And just so you all know the continuum of what the pathologists are looking at, so you see how there's this white space in the middle of this duct? So it's a normal duct, and the white space truly is space. This is an empty duct. It's normal. If you were to see these cells fill a little bit of the duct, that would be at least atypia. As they fill up the duct, that would be something called ductal carcinoma in situ, or DCIS. And if they burst out of the duct, that's what we would call invasive cancer. So that's the continuum of the things that the pathologists look at. And it truly is a continuum and not discrete categories, which is why sometimes the pathologists don't all agree with each other. But moving on, okay, so now we know that there's these two types of cells. So these two types of cells give rise to two of the 4 molecular subtypes that were originally identified by Perot and colleagues. So luminal breast cancers are often ER positive, and basal breast cancers are often triple negative. And so this is just some examples. And so you might say, wow, well, why is this important at all? And it's because of several things. One, imaging can actually reflect which molecular subtype a patient has. And also the molecular subtype very much determines the treatment. So different molecular subtypes also have different survival, metastatic spread, response to treatment, and even disease presentation. And we'll go into a little bit of this. So for a luminal A subtype, and these are those luminal cells, they have the estrogen receptor positive, and some of those women could just have hormonal therapy and be just fine. That would be an anti-estrogen. These tumors tend to respond less well to chemotherapy. But luminal B tumors, a slightly different subtype, they do respond a little bit better to chemotherapy. And then the basal subtype responds generally very well. And the HER2 subtype has that Herceptin targeted therapy, which has revolutionized treatment for this subgroup. And there's actually a number of clinical trials now looking at, for this subtype, just treating them with immunotherapy, so no chemotherapy. And those clinical trials are ongoing, and I'll tell you the results are fantastic in that the entire tumor shrinks away just with the immunotherapy. So good things in the pipeline also for that subtype. So here's an example of how the molecular biology is reflected in imaging. And once again, why is this important? Because what we're saying here is that when I look at this tumor, which here is right here, and I see that it's spiculated, and I see that on ultrasound it has an echogenic halo and it's irregular, and I can see the spicules on the breast MRI, I can begin to say, I think this tumor is going to respond well to anti-estrogens. And actually, when we feed this information into a computer, which is part of what radiomics is, it's looking at all these imaging features and putting it together. The tumor may be able to fairly accurately tell us how to treat this breast cancer. So this is an example of a luminal cancer. It tends to be spiculated. And this is it on ultrasound, mammogram, and MRI. And spiculated are just these little kind of things coming out here. It's the opposite of circumscribed, which means basically you took a pencil and you could trace a line without moving your pencil, just a smooth line. And spiculated is that you'd have jagged edges if you tried to trace a line. So this is an example of a tumor that would present if I were to see this in clinic. This woman had a mammogram. She has calcifications here. They would look abnormal to me, but all of this actually looks abnormal. And I would immediately start to think calcifications, large tumor, HER2 enriched. This is what they look like. And this is this on MRI. And basically this is all tumor in the breast. This is skin thickening in the breast. And this is it on ultrasound. And even though this tumor is big, it is possible this woman gets immunotherapy and this shrinks away to absolutely nothing. And at that point, the prognosis would be outstanding. And our hope is that we can use imaging, even at this very early stage, to predict how the woman should be treated so that her tumor basically completely goes away with chemotherapy and she doesn't get any drugs that are not useful. And so those are the calcifications. A lot of people ask me, what are these calcifications if they've been recommended for biopsy? They're these little white specks. And some of them to us look normal and some look abnormal, and these look abnormal. So this is the final subtype is the basal, the triple negative. And now this is a mammogram, an ultrasound, and an MRI. And I'll just go over the MRI. Here, you see how this is not a jagged edge? this is what's called a circumscribed edge. This is more likely how these tumors present. And then the black hole in the middle means the tumor is centrally necrotic. It has grown so quickly that it's outgrown its own blood supply. And so it's dead in the middle and it's alive on the outer edge. And the information from this imaging already, if I was reading this, I would say this is 99% probability a triple negative breast cancer. And even the fact that it's centrally necrotic in the middle gives you an idea about the best way to treat this tumor. But once again, even though the radiologist can at this point say this is likely a triple negative, we would feed all of this information into a computer to really get an idea, where the computer comes out and says, you know what, this is possibly the best way to look at this and to treat it. And that's just some more examples of tumors that are circumscribed here. And that's one of the hallmarks of those triple negatives. So what about radiomics? So we've been talking a little bit, I've used this word. The radiomics refers to high throughput extraction and analysis of large amounts of features from images to build different models, models of prediction, models of therapy choice, any type of model relating the image features to the phenotype or the protein signature. Radiogenomics is similar. It's the correlation between imaging features and gene expression of the cancer. But going back to radiomics, so when the computer looks at the images, it actually gets a lot more information than I can articulate. Now, we never know what our human brain is processing, but it's actually taking information about the margins on a level that we can't even see. And we train the computer by saying to it, you know, for example, here's a series of tumors, this is the molecular subtype, this is the gene expression, this is how the people were treated, this is how they did. And then we train it, and then we give it a new set and say, now we want you to give us the correct answer on the second set, where we would also know all that information. And that's how we come up with a computer modeling program that's able to make useful predictions for us. So this just goes into a little bit about why you would want to use imaging to do this. When you take a biopsy from a breast tumor, the biopsy represents a very small amount of the actual tumor, and breast tumors are very heterogeneous. One way I might be able to relate this to you is if you know, the doctor were to say, well, the tumor is partly ER positive, but it's partly ER negative. It's not all one or the other. And this is just a fact, but the imaging can see the whole tumor. And so it's not subject to something like sampling error, where you might sample one part but miss another part. And we'll go into that a little bit more. So imaging, mainly it's accounting for heterogeneity, and then we want to identify patients who don't need treatment or what is the best treatment. So I'm going to give you just a little example of heterogeneity here. So this now is a sample from a breast tumor. So this is something that the breast radiologist took out and gave to the pathologist. And here the pathologist stains it for HER2, and the HER2 is in brown. And so anything brown is staining positive. And you can see that part of the tumor stained positive, but part of it didn't. Here it's negative, here it's positive. And in addition to that, if this is all you had, this part in the middle, you might say it was ER negative, because here's the middle part over here, no ER signal. But look over here, this is ER positive. Well, you really don't want to miss that, because this woman needs anti-estrogen therapy for the ER positive portion of her tumor. And this here is just this blown up where you can see it's something called a FISH test for the HER2. And you can just see this sharp demarcation between HER2 negative and HER2 positive. And this is an example of how very positive it is in areas that it is positive. But this is a very, very small piece of tissue here. And so you can imagine on the level of the tumor, there is heterogeneity that pathologic sampling would miss. And that is why it's so important to use imaging, because you can see the whole tumor when we predict which treatment or treatment response.
Hello? Hello?
Do you still hear me?
Yep.
Okay. All right, so this is just an example of radiomics, and we talked about what radiomics is. That's when we have the computer look at all of these imaging features, and then the computer can tell us from those imaging features whatever the query is. In this case, it was recurrence risk. In another case, it could be treatment response prediction. And this is just a paper that we published many years ago. It was actually featured on the cover, where you can see here that, you know, basically this was using just standard imaging features to predict recurrence. And then when we were feeding all of the features, both seen and unseen, into a computer, this curve here went to this. And basically what this is telling you, one is perfect. So this green is closer to perfect than the red is. The closer you get to perfect, the better. This is really good prediction for recurrence risk that the computer was able to do based on the imaging features. And this is just an example of something that we've done and we've published using computers to predict recurrence risk. So this is just another example. This is a triple negative breast cancer here, pre-treatment. You can see it's circumscribed. You can see it's centrally necrotic. It's everything we said it would be. And then post-treatment, even though you see a little bit here, this is a breast MRI, this is just scar. This tumor is completely gone. It responded fully to treatment. And the prognosis here would be outstanding. This is what every patient wants. But this is an example where this could be predicted with radiomics. And this is just an example of the pre-treatment biopsy. This is pathology here. All of the little blue dots are cancer cells or purple dots. And here in the post-treatment biopsy, this is just scar. So there's nothing here. So this is another example of a paper that we published more recently, where we were able to use radiomics. So again, plugging those imaging features into a computer to actually predict survival. And this is just an example of an imaging feature where no recurrence was predicted. And this is an example of an imaging feature where recurrence was predicted. And you might say, well, you know, this is great, but this isn't really helping me predicting survival. But it is helpful because this was predicting survival based on standard therapies. And so in this case, if the prediction wasn't good, you would go to an alternative therapy. So this is just an example. We've come a long way since my mom had breast cancer. Whereas, you know, I felt like going through the treatment with her more as a layperson, because it wasn't my specialty at the time. You know, she was just on the same wheel as everybody else. But now we are able to look at that mammogram. And this is a woman with a high breast density. We're able to look at the tumor sample. We might combine that with some gene expression mapping, information from the MRI. We might combine it with radiomics. This is actually something called a heat map. It's the way the computer looks at the imaging features. And then one more thing that we haven't talked about, which is functional imaging. And I'll go back to that a little bit and use this all to tailor treatment. So now we can put everything together for patients to make sure that they get a treatment that works. And I can tell you at Penn, that is a very high priority for us. and it is something that we are doing. Precision medicine is really being implemented there for patients. And all of this is done up to here is done in the clinic for patients, including gene expression. The radiomics hasn't quite made it into clinic yet, but we're hoping soon. And functional imaging is certainly in clinic as far as FDG PET scans. Some of you may have heard about that. That is a PET scan to look at sugar metabolism in tumor, and that gives us a lot of information. But also at Penn, we're testing a lot of new radio tracers that measure different things that they are going to help us treat the tumor. And let me tell you, one of those is a tracer that actually measures estrogen levels. Now, that's not something we need to do so much in someone who just has a tumor in their breast. And this is actually a tumor in a breast on a patient. So this is a breast, and this is a breast, and this is actually their heart, and this is a lymph node. Because you can look at that by pathology, but for patients with metastatic disease, if we want to know, is all that disease ER positive? Is just some of it ER positive? Is anything outside the breast ER positive? That tracer has a lot of potential. And then also the main, one of my main research focuses is a tracer that measures PARP expression. And we hope to eventually use that to predict which patients should get a breast cancer drug that you might have heard of called a PARP inhibitor. With that use certainly expanding. So this is just another thing in this whole group of things that you want to do to really understand the tumor, to get Sally, Molly, and Mary off the wheel that everybody goes on and get them on their own personal path that's going to be the best for them, where you don't overtreat them, but you don't undertreat them. And the functional imaging, and this is basically looking at the expression level of different proteins in the body, or in the case of PET imaging, looking at sugar, looking at glucose metabolism, that this is a way to decide what to do. So in summary, we talked a lot about how imaging features are associated with gene expression, how morphology, that's what we look at with imaging, reflects the biology, and how imaging features can actually be used to predict tumor behavior. Biology can actually be imaged. And I thank you for your attention. Thank the Komen Foundation that has supported a lot of my research into the PARP radio tracer and into some other radio tracers that we didn't talk about, but that we're hoping to use to combine with all the other modalities that we have, so that we can truly offer a personalized therapy plan to every patient. So thank you.
Very neat. Thank you.